um, it'll interest you, and we'll have lots of questions and some good discussion. And I am by myself today, and I'm with one computer. So if we have questions or comments, we may have to go ahead and just use the chat feature at the bottom of your screen, just so I can be sure to get all those questions and comments in. I welcome that throughout the program today. Whatever comes up for you, comfortable sharing, I'd love to hear from you. So my name is Beth Williams. I work for the University of Maryland Extension through the ROPTA project, which stands for Reinforcing Overdose Prevention Through Training and Advocacy. We have several grants that fund these programs. We do longer programs like a mental health first aid, which is about a 7-hour course. We do programs like these, which go from anywhere to an hour to maybe hour and a half or so. We'll be out of here today in our designated time, 11:30. I always try to keep you all, on schedule, because I know your time is valuable and it's much appreciated. So I will be, like I said, we'll be covering this course. We're going to learn a lot today about opioids, and I kind of called it. I've nicknamed this course Opioids, Everything You Need to Know from Soup to Nuts, because we're going to cover a lot of material about what opioids are, why we have had such an epidemic, what the numbers look like, how some things can be prevented, etc. So I hope you enjoy the course. Again, please use the chat at the end or anytime you want to, and throughout the day, and we will get started. So I will be also monitoring the chat and make sure nobody else comes in through the waiting room. So, like I said, today we're going to be looking at the opioid public health crisis. And when we talk about opioids, we talk about, first and foremost, the brain, the effects on the brain. The brain is like with any chronic disease, there's a primary organ. And when we talk about opioids, we are talking about the brain as being the organ that is affected. And I'm going to put my notes here. If you can read them, I've taught this a lot of times, but I always like to be thorough. So when we talk about addiction, we know that addiction is a chronic brain disorder, and like other diseases, it should be treated medically. It is not a choice. It's not a lack of willpower on someone's part, but it is a disease that affects the actual structure and functioning of the brain. Okay. So there's our beautiful brain. There are different between those who use substances and those with addiction. So everyone that uses an opioid get addicted. We do know, however, and we'll learn lots more about this today, that opioids are highly addictive. So if someone is on a prescribed medication, they're going to have to be, really in touch with their physician, monitored well, use the medications just as directed, etc. So addiction suggests, a more severe turning point where changes in the brain actually occur. It changes both the brain structure and function. And what began as a choice, the person, of course, the first time they pick up any substance, whether it's alcohol, tobacco, any other drug, marijuana, or an opioid, the first time is always the choice. And that's why I have spent a lot of my career in prevention, because I really feel if we can kind of push off that choice or get our young people to not make that choice to pick up a substance, the better off we will all be, obviously. But what began as a choice becomes hardwired over time into the brain and becomes critical for our survival. And we do also, and I'm not sure, I'd have to look at my book if that's one of the ones I'm scheduled to do with you all, but we do have an excellent course called The Brain and the Disease of Addiction. And that goes a little deeper into what we're talking about here. And let me just also say, I forgot to mention that this is a course from the organization Overdose Lifeline. They provide many courses. They are a nonprofit organization out of the Midwest, and they are really, I feel, at the forefront of a lot of these issues. These courses are updated constantly. They're very relevant. They stay very, very, on top of the new trends, et cetera. So I encourage you, if you have any questions or you want to look into Overdose Lifeline, you can go online and find them. They're a terrific agency. So let's go to how many Americans are affected. In our country, we have about 20 million symptomatic people. And when we say symptomatic, we mean that their disease is active. The disease of addiction is active. So they are actively using that substance of choice. In this case, we'll say opioids. We have also 23 million that are living in recovery who are non-symptomatic. So they are, working a recovery program or, staying abstinent or, even doing some harm reduction regarding their addiction. So that means in total that we have 43 million Americans affected by the disease of addiction in some way or another. And that's not including the families, friends, the societal effects that are experienced by all of us. Okay. So we're going to talk a lot about fentanyl today, and I'm going to give you a good opioid overview so we know exactly what opioids are, how they work, why are they, risky, etc. Okay. And again, if you have any questions, comments, need some elaboration on a point, please put it in the chat and we'll get right to you. So when we're talking about prescription opioids, we're looking at medications that can be used to treat moderate to severe pain. And often this may be following surgery, an injury, or health conditions, long-term conditions that need management of pain beyond what someone can get over the counter. If you've ever been in the hospital and you've had surgery, you have had an opioid. I mean, that's morphine is a pure natural opioid. And anyone who takes prescription opioids can become addicted. So what we're seeing here are some examples of kind of what they look like. Far on the left, there is a opium poppy. They are grown mostly in very warm climate areas, a lot over in parts of Asia. In Mexico, we can even grow it here in the US, but I don't think there are many places amenable to the climate that it needs in our country. Most of what we have in our country is imported. In the middle, we have a semi-synthetic opioid. So we're looking at, pain medications, things like morphine, fentanyl, those types of things. So we're seeing capsules and pills. There's Percocet there, OxyContin down here in the gray pill. To the right here is heroin. Usually it's white, tan, or gray, looking in a powder substance like we see here. And semi-synthetics just mean that they have they start out as with a natural basis chemically, but then they are, other chemicals are added to it. So medications that we're getting over the counter, in a hospital, are not going to be purely natural, other than morphine. And then on the right is fully synthetic. So we have heroin, fentanyl, some of those types of drugs that are fully synthetic, lab created. They mimic the formula of the natural opioids or the semi-synthetic, but they are fully synthetic. So fentanyl is used medically still in the hospitals and for pain management. Obviously, it can be prescribed. It has to be very carefully monitored. And then we'll talk in a little bit about counterfeit fentanyl or street fentanyl, which is a little bit different. But when we look at fentanyl in general, it is 50 to 100 times stronger than morphine. And usually morphine is the one that's the strongest, but fentanyl is even stronger than that. So here we go again. Prescription opioids, they can be used to treat moderate to severe pain. Increased acceptance and use for the treatment of chronic non-cancer pain. Pain clinics about 10 to 12 years ago were very popular. I'm not sure we have as many as we used to, because there were problems and there was some abuse on the part of patients and the clinicians. These opioids can be used for a number of chronic pain issues, despite the serious risks and the lack of evidence about long-term effectiveness. So again, anyone who takes prescription opioids can become addicted. As many as 1 in 4 patients that receive long-term therapy struggle with opioid addiction. So 1 in 4 who are on using prescription opioids may struggle with opioid addiction. So it's very important for patients and providers to discuss the risks of opioids and to also consider alternative therapies. Again, somebody may not have alternatives if their chronic pain is, unmanageable without an opioid, but there are ways that people can kind of mitigate that. They can look at the risks, consider alternative therapies, using fewer prescriptions for fewer days, lower dose, etc. So it's very important to be in contact and in a good, partnership with your physician. So tips for reducing prescription opioids risks are to, again, talk to your doctor about non-opioid pain management and the risks involved. Only take prescription medicine that's prescribed to you. Don't share medications with others, and take medicine directly as prescribed. And then anything that is an unused or expired medication, opioid or not, we'll talk a little bit about that later when we talk prevention, but we want to keep that out of what we say little hands and little paws, keep it out of reach of pets, of children, of teenagers, keep it in maybe a lockbox or a locked cabinet, and then properly dispose of when you are finished with it. A lot of us, get in the habit of kind of keeping medications around just in case we might need them. And basically, we want to just get in the habit instead of getting rid of medications when we're finished with them. Just as an aside, and this is from another course that I teach, but most young people who use opioids report that they are getting their first opioid. The first use of opioid comes from something in a medicine cabinet, either in their home, in a relative's home, in a friend's home. They may go to, believe it or not, open houses, and people are selling at home and go through medicine cabinets. So we want to keep this medication non-accessible, except for those that legitimately need it. Okay. So again, just as some asides, and we get more into some of this prevention in a little while, but talk with your loved one if you're concerned about addiction. Let them know that you care about them. We need to be patient and open. Really, talk with our kids about this at early ages. And if we know someone, again, encourage them getting help and help them look for treatment, maybe even offer to go with them in treatment for their treatments. Okay. So fentanyl 101, used in clinical settings since 1968 for pain management or surgical. Illicit fentanyl, again, illicit, that means something that is not prescribed, but comes, we used to call street drugs. Somebody is buying it or getting it from someone else other than a physician. Illicit fentanyl is the primary driver for the overdose health crisis today. Illicit fentanyl, it is cheap to manufacture. It has no smell. It has no taste. very hard to detect if someone is using it in terms of, the obviousness of the drug. There are symptoms and signs in behaviorally that we'll look at in a little while. The components are easy to require and very cheap acquire, and are very concentrated. So a tiny little bit of fentanyl goes a long way. Fentanyl, in terms of the street market, comes in a white, gray, tan powder form, can be injected, smoked, or snorted. And also there are reports across over 20 of our states of rainbow fentanyl, and I'm not sure if this one has a picture in it or not, but fentanyl is being illicitly manufactured to look like candy or, to be very appealing to young people. So we have fentanyl out there that is in pills or capsules that looks like Skittles, that looks like Sweet Tarts, and is actively marketed, so to speak, on the internet. So let's see, something else I wanted to say about fentanyl. Anyway, it is, like it says, it's the primary driver for the overdose crisis that we have today. Oh, and what I was going to say in terms of the components being easy to acquire, if somebody has a halfway decent knowledge of chemistry, they could put together something that resembles fentanyl, or has some of the basic makeup of fentanyl in terms of chemistry. And they can also get the components in terms of pill molds, what do you call them, like adulterants, all of this kind of stuff can be accessed on the internet. So people basically, down the street from us could be manufacturing street fentanyl. Okay, so a couple of myths we're going to look at. We've heard a lot about people dying of overdoses of fentanyl because they touch it. We hear this a lot of times with law enforcement folks, that they will respond to an overdose or, they've pulled somebody over and the person, they touch the person's jacket or something and they overdose. And actually that is false. You cannot overdose by simply touching powdered fentanyl. We certainly don't want to go around touching it. We, advise that people who are treating for an overdose, or law enforcement or medics, obviously wear gloves and don't get real close to the fentanyl, the powder that may be obvious in a car. But fentanyl has to be introduced into the bloodstream or mucous membrane, for someone to feel the effects. So the person may not overdose by touching it, but if they're close enough and breathe it in, that certainly could cause an overdose if it was of a high enough, strength. Okay. Dissolving the powder in the liquid does not change this property. Wet objects do not pose an increased risk for an overdose. So just by touching it, you will not, you won't overdose. Another response is that symptoms such as alertness, rapid heartbeat, hyperventilating, sweating, chills, etc., you can see them there, numbness, are not typically associated with opioid or fentanyl overdoses. They may be more commonly associated with some kind of an anxiety disorder or with a stimulant drug. These are certainly observations or symptoms or signs of use of a stimulant drug like cocaine or some of those other in that particular, my mind is going blank now, but like some psychedelic drugs as well. But that is not typically associated with opioid overdoses. So this is basically a slide. If someone is, responding to an overdose, somebody is a police officer or works with folks that maybe are using fentanyl. Personal protective equipment, we're all familiar with that from back in our COVID days. Wear masks, wear goggles if necessary, gloves, washing hands with soap and water. Do not touch your eyes, nose, or mouth if you've been around someone or treated someone or helped someone who maybe had an overdose until you can, wash your hands, use hand sanitizer. Do not eat, drink, smoke, or use the bathroom. I don't know what that's about. That's kind of a weird slide. Some of these are newer slides. They, like I said, Overdose Lifeline likes to update these frequently. But I think you don't want to touch anywhere on your body until you have washed your hands well with soap and water. You got to keep it away from those mucous membranes. Okay. So, the opioid public health crisis, and this will be interesting because this will kind of explain why it got to be. How did we get it this bad? How did this become a crisis? The use of opioids. Now, some of these, before we start talking about data, I want to just bring to your attention that some of these slides might say 2022 or 2023. You all probably know that data, there's always data lags, especially when it comes to health-related data. There are many sources that this data comes from. The data that Overdose Lifeline gets is directly from CDC, which, we know is the top agency in the country for health-related matters and research and education. But we need to keep in mind that there are so many people who are overdosing. There are so many areas to look at. Hospital data comes in. Local data comes in from maybe a police department or a hospital or a clinic. So it takes a while for data to kind of filter out and be examined and then get to us in the field that I'm in to educate with some of this data. And it can take 2 years or more sometimes. We can get what they call provisional data, but in terms of the data we'll be using today, a lot of it you'll see these dates. And 2022 or 23 would be the most recent we could get. So with that being said, I can't see the bottom of my screen here, so let me see if I can get this slide. We're looking at, hide the screen if I could possibly, let's see. Well, this is looking at overdose deaths. So we're looking down here way at the bottom at 1999, where we had 16,849 overdose deaths. And you can see how in that, maybe, what is that, 19, 12 years or so, how it has steadily increased. There was only one slight area up here in 2018, 2019, where there were some small decreases, but in 2022. But you can see the highest that it's been in terms of overdose deaths in our country is 106,699. So accidental overdoses are the #1 leading cause of all accidental deaths in our country. Nearly 107,000 Americans died of drug overdoses in 2021. That was probably the highest. It's a little bit lower now, as we saw on the previous slide, but still, that is more than all accidental deaths by car accidents or guns combined. So 75% of that is due to opioids, with 88% specifically fentanyl. I probably mentioned earlier, fentanyl is everywhere. It is what the problem is today. We see very little heroin. We still are seeing prescription misuse, but by far, fentanyl has become, like we said earlier, the primary driver of this epidemic. But we can see over here, fentanyl 88%, opioids 80,000. 80,000 out of those accidental overdoses. So this is a really interesting screen. We are seeing kind of 3 phases here. So we are looking at the dark blue line right here is let me see, make sure I'm in the right place here. This dark blue line here is representing heroin use. So in 1999, heroin use was, you can see probably about 4,000 or so deaths. And the line, if you follow the dark blue line here, it kind of goes a little bit and peaks up here at around about, what's that, 12,000 or so. And then it kind of goes back down. Nothing dramatic in terms of sharp rises or sharp decreases. When we get to the lighter blue, that is prescription opioids. And we can see, again, the line is crossed over. It kind of mirrors somewhat toward the end the use of heroin. Then we get to the yellow line. This yellow line is fentanyl. And so you see fentanyl, again, it was kind of, staying steady in terms of the numbers. And all of a sudden around, 2011, 2012, all the way up, it started to peak tremendously. It shot up to where it started way down here at, very low percentage of overdose. And by the time we got up here, around 2020 or 2021, and even now this trend continues to go up. You can see it just shot up. So why did this happen? Okay, and again, there we're talking about the waves, where we had the waves of heroin and prescription, and then wave 3 came around 2012 or so. So what happened here? First of all, let me see, we got a chat here. Yes, I know that, and I'm having a hard time getting rid of this. Thank you, Joy, for that. There's my black bar is on here, and I'm having a hard time without. I don't really want to go into fooling with this black line here. Let me give it a minute here. Let's see if I can fix that. It's getting in my way too. But I have this pretty much memorized, but let me see. Okay. I apologize for the black line there. I'm not sure how to get that out of there. Does anybody have any suggestions? Okay. Okay, it's gone now. Good. Okay. Yay. Okay, so thank you for bringing that up, and we can see, just to review this, wave 1 was prescription drugs, where people were, using drugs that were prescribed for others. They were misusing drugs that maybe were prescribed to them, and that was causing the overdoses. So right around here in the mid-2000s, wave 2, the government started cracking down. A couple things happened. The first one was the government, local governments and the federal government started really putting in some regulations in place to monitor and reduce the use of the prescribing of prescription opioids. So when that happened right here, we also had some opioid lawsuits, opioid manufacturer lawsuits right here. So a lot of, including Maryland, governments really clamped down on prescribing practices. So in Maryland, we have a prescription drug monitoring program that came into effect, where physicians are tracked and pharmacists are tracked, as well as how many prescriptions were given out. And even patients who were using opioids were, monitored to make sure that they weren't misusing, or it was properly prescribed for them. So when that happened, a lot of physicians decided, well, I'm not going to prescribe opioids anymore, or I'm going to really cut back to protect myself and my practice and my patients. So that's when wave 2 started, because as we know about addiction, you can't just cut somebody off. If there's a patient who is addicted to a prescription drug, they cannot just be cut off of that drug. It has to be tapered down. There has to be some treatment available, etc. And people were getting desperate and going to the streets and looking for what they could get on the street to replace that prescription opioid. And of course, illicitly, but of course, at that time, it was heroin. And so heroin came in and started rising right in the middle here between wave 2 and wave 3. And then what happened is illicit fentanyl came along. And again, it's a stronger effect. It, has a stronger sedative effect. It's cheaper than heroin, etc. So once people started using heroin and then fentanyl came along, and oftentimes fentanyl initially was cut with heroin, and people would actually look for that because the effect is stronger. And so then we saw overdoses of fentanyl go up. Okay. So per 100,000, the overdose death rates, this is a map of that. We see Maryland right over here on the right, and that corresponds to a 41 to 50 persons per 100,000 for overdose rate. And you can see that's right in the middle of some of these others, which are higher. You see New Mexico at that time had a 51 to 60% rate per 1,000. So as we see, most of this began with the eastern states, eastern part of the United States, which always seems to be the case. I'm guessing because there are more larger metropolitan areas here and more people and more possibly access to opioids. I'm not really sure, but we always see it over in this part of the country when it starts off. We've got other drugs in the pipeline that we're watching, and most of them have started up here in the Pennsylvania area, Washington, D.C., West Virginia, etc. Poor West Virginia seems to have been hit the worst by the opioid crisis in terms of the overprescribing, etc. And when we talk about the lawsuits, we can talk a little bit about that too. But we can see that, we've got Louisiana, Tennessee, Kentucky, West Virginia, Virginia, Delaware have been the highest, and they had the highest rates per 100,000, and probably still do today. So Maryland overdose deaths. We go up to 2022 here, which is the latest data, but we can see ours have, they've gone up a bit and then have just kind of sloped down a little bit. The latest estimates that we've had. 2022, it was 88%. 88% due to opioids and 93% due to fentanyl or synthetic fentanyl. So again, in Maryland, our rate is 42.8 per 100,000, and we had 2,737 deaths. Our overdose rate actually has improved a little bit. It's reduced by 4% over 2019 numbers. Okay. Just, for reference, I put Washington, D.C. in here, which has been one of the higher areas to be affected by opioid overdose deaths. We can see that the 2022 estimates were 79% due to opioids. 96% of those opioid deaths were due to fentanyl or synthetic fentanyl. And they have had in 2022, 27.8% increase in their opioid deaths, overdose deaths. So nearly 1.2 million in our country have died between 1999 and 2022. And again, we mentioned earlier that that is the leading cause of accidental death by far than any other accidental death in the country. And incidentally, that is also the toll from the crisis between 99 and 2022. Overdoses killed this 1.2 million. I don't know if it'll come up. There it is. 301 Americans die every day from an overdose, which is one dying every 5 minutes in our country, which is really staggering. That exceeds the number of U.S. service members who have died in battle in all of the wars fought by the United States. So that's how huge this problem is. All right, so in terms of street fentanyl, since that's what we've been talking about, it is often added to other drugs because it's extremely potent, and it makes drugs cheaper, because when you have to add less of something to what you're cutting it with, it becomes, cheaper. You're not using as much fentanyl. It's more powerful, more addictive, and more dangerous. And just as an aside, and we'll talk a little bit about this in the addiction class, the brain and disease of addiction class, just like some anecdotal observations. When people, my husband used to work in a large city for the fire department, and he was a medic, and he and many of his colleagues would report that whenever street drugs are being sold, first of all, they're sold and marketed as being more powerful. A lot of times the manufacturers of the street drugs the dealers will give them, fancy names. This is a blue cap. This is, a Tom Brady. This is a whatever. They will give it a catchy name, but they will also advertise it as being more potent than the next dealer. So you would think, logically, that people would want to stay away from that. Oh my gosh, it's got more fentanyl in it, but actually that would drive people to use that more powerful drug, because we know about addiction, especially opioids, that, people who use will always be chasing what they call chasing that first high. I had a client when I started in this field when I was 23 years old, and I was doing addiction counseling, and he told me, my very first client, and he told me that when he used heroin for the first time, which is a very strong opioid, when he used heroin the first time, it was the best he had ever felt in his whole life. And so people want that. They want that feeling of not having that, mental pain. They want to have that feeling of feeling relaxed, not worried, etc. So, when we put fentanyl in the mix, that makes it even more potent, and it's driving people to use it. So it is rare to find people who only overdose on cocaine or methamphetamines or even heroin. As heroin is really not being used much at all now anymore. Fentanyl is used to lace the illicit drug market because it's very profitable. And you'll remember when we were looking at the slide earlier of photographs of opioids and the different types of opioids, you saw that powdery tannish powder that I mentioned was heroin. And when people are using drugs like fentanyl or heroin, there's very little fentanyl or heroin in them to begin with, because it is cut, what they call cut, or mixed in with an adulterant of some kind to make it go further. So it could be mixed in with baby powder. It could be mixed in with powdered laundry detergent. It could be mixed in with, what's the other one they use? Any kind of a powdery substance that can be cut and then, again, used to inject or smoke or put into a liquid or into a capsule. So it is not just, you're buying fentanyl on the street, but it might be a tiny little percentage of fentanyl, and it's cut with lots of other adulterants. And so what happens is a lot of times people not only get the effects from the drug, but they may get sick from what it is cut with. That's just an aside. Okay, so when we're talking about illicit fentanyl or counterfeit pills, 6 out of the 10 counterfeit pills that were seized by the DEA contained a lethal dose of fentanyl. So that is 60% of all the counterfeit pills out there. Now, when we say counterfeit pills, these pills are marketed. Yes, they're marketed as fentanyl or an opioid, but maybe that opioid is Percocet, maybe it's OxyContin, drugs that do have legitimate use, but sometimes people will want to misuse them. So they will go to the internet and buy what they believe is a Percocet or an OxyContin. There are other folks, particularly our young folks, who may want to buy drugs such as Adderall, because Adderall is a drug that is used to treat ADHD disorders in youth. And our young people feel like, well, if I use Adderall, maybe it'll give me, I'll be able to concentrate more, I'll be able to focus, I'll get better at my sports or my schoolwork, or whatever it is I want to excel in, this is going to help me do it. And it's not true. Those drugs, Adderall and what's the other one? Ritalin, are used to only for people who have that diagnosed disorder. So somebody trying to buy it counterfeit on the internet, what they think may be Adderall is really a fentanyl pill. So again, very dangerous. And as we remember, no taste, no smell. So it's very dangerous, and you really honestly can't tell the difference sometimes. So fentanyl overdose is now the #1 cause of death. Talked about that. Overdoses with opioid involvement. You can even see with a psychostimulant drug like methamphetamine, 66% still involve opioid. So it may be cut into that drug. Same with cocaine. And then some of these more depressant drugs at the bottom, they may look like it's an antidepressant, but it really may be cut with fentanyl. So when we are looking at anyone using substances, we have to always think fentanyl these days, because that's most of the time fentanyl is involved. And this is just showing pills containing fentanyl seized by law enforcement. 58.3 million counterfeit pills laced with fentanyl. And it only takes 2 milliliters, I think it is. I have a really good slide, but it's not in this particular presentation, but it takes a small little, like a few grains of salt size of fentanyl powder to be fatal. Okay. Any questions? I know this is a lot of information now. I appreciate you hanging through this. So what is causing this? What contributes to this epidemic in our country? What are the contributors? What are the risk factors? So we talked earlier, opioid prescribing practices are a primary contributor, because we saw in that slide earlier with the, which had the opioid prescription, heroin, and fentanyl. Between 1991 and 2012, prescribing practices and prescribing opioids tripled. We saw in 2012, of course, that started to be cut off, and that caused the other increase in other opioids. So there were 131 million prescriptions written in 2022. Prescriptions for pain medicine. So we're looking at 39.5 for every 100 persons in this country. That's a third of this country who, in terms of looking at the numbers, for every 100 persons. So let's look at Maryland again over here in the light blue. You can see that our numbers are 36.1, which is not low, but prescriptions for pain medicine were written. Maryland has a very rigid and very strong prescription drug monitoring program, as does Delaware. And both came about because our states are so close to one another. Especially, I don't know how many of you may live down on the Eastern Shore, but we have, people go to Delaware, between Delaware and Maryland all the time, to go to the grocery store, to go to the doctor, to go to school activities, et cetera. So those two states, we've worked very closely. So if people can't get a prescription in Maryland, so they hop over to go to a pharmacy in Delaware, they are still monitored using the same program. So that is why our rates are pretty low, but you can see some of these down here, the rates are incredibly high, over 50%, 50 out of 100 people are being prescribed pain medicine. Okay, so in terms of the settlements, you all have probably heard of this. Maryland received a pretty good chunk of money from these settlements. let me find my sheet here so I can get a little more detail with that with you. But those came about from pharmaceutical companies who gave incentives or kickbacks to hospitals and physicians and clinics to use their newly developed pharmaceuticals, opioid pharmaceuticals. These included Purdue Pharma, who made OxyContin. When they created OxyContin, they marketed it as the next best thing there will ever be for other than morphine for people who have chronic pain. And again, we know when prescribed correctly and when monitored and when used only for pretty much very severe pain for very severe diseases, something like that may work. But they started using OxyContin in pain clinics, in outpatient clinics, and through physicians' offices, because they were given incentives to promote the use of OxyContin. Then there was another settlement with Johnson & Johnson, some larger distributors of the OxyContin for McKesson, Cardinal Health, and Amerisource, which were also really over-prescribing OxyContin. So most of the settlements have come to the states. West Virginia was one of the states that was hit the worst of anywhere in our country, and they are still struggling with the number of people who are addicted to who got addicted to OxyContin. Some of these, like the Purdue Pharma, was a $10 billion settlement. Some of them got $4 billion from the Sackler family. There were some others over on the right that there were some deals on those other three distributors that the government has made. So like in Maryland, we have an opioid restitution fund, and those funds, pretty substantial, do go to the monitoring programs and to some prevention and education programs, and to kind of get a better system of treatment, or a more coordinated system of treatment. Okay. So again, there was misrepresentation of these drugs by even the New England Journal of Medicine. Now, this was before all the drug companies and all of that came into play. This was 1980. But this letter that was printed was referenced by physicians, pharmaceutical companies, etc., that there would actually be fewer addictions when the prescribing was occurring. When people prescribed opioids for a not normal, but like a chronic pain, there would be fewer addictions. And so that article was quoted for quite a long time. And, we know in the medical field, it takes a long time for us to then, shift a little bit to the other side. So marketing and to physicians and direct to consumer advertising may also encourage overuse. We know today, we don't see opioids advertised on TV, but if you're watching the news at night, you will probably see at least 5 to 6 ads on TV for Wegovy and some of these other drugs. I forget the names. I just remember Wegovy because I feel like I see that ad all the time. So it is heavily marketed and advertised, so people know it's available and they want to use it and see if it will help them. Not necessarily, like I said, the opioids anymore. I don't believe that's allowed, but other medications. So this is going to kind of go a little bit more in depth about that. So the paths to prescription opioid use disorder or addiction. We see prescription misuse, and we've talked about that a bit today. People use prescriptions that are not theirs. They use prescriptions they don't need. They don't use it according to a doctor's orders. They may use more than directed. They may try to get prescriptions from different doctors or different pharmacies. So we see a lot of misuse in our country from of opioid use, of opioids and other medications, I'm sorry. Culturally and socially, we see that Americans perceive pain, higher rates of pain than almost any other country. We kind of don't like pain a lot in this country. We don't like discomfort. We get a little bit impatient with things when they're uncomfortable. So in 2017, there was a paper published that Americans appear to be in greater pain than other countries, with 34% reporting they experience frequent pain. So again, when culturally, it's not abnormal to want prescriptions. We have the ads thrown at us. We want the easier fix maybe, or the quicker fix, and we don't like being sick, etc. In terms of the pain being a fifth vital sign, in the 1990s, pain was added. When you go to the hospital, they would not only take your blood pressure and your heart rate and your oxygen levels, etc. They would ask you, how's your pain? From on a scale of 1 to 10, what's your pain levels? And so that got to be a very important part of your initial assessment at a hospital or a doctor's office. And as we know, on a scale of 1 to 10, everybody's scale of 1 to 10 is going to be different, right? And it cannot be measured objectively as a blood pressure or a pulse or a oxygen or any of those. So hospitals were also receiving incentives and reimbursements, and they would also, with it being a vital sign, they would ask when, in terms of quality care or patient satisfaction, they would ask, how well is your pain managed? And if a patient would say, well, this hospital is terrible, they didn't manage my pain, I told them my pain levels were high and I couldn't get pain meds, then the hospital would get lesser, positive feedback. And what happens then? Then insurance companies get involved and try to, come down on the hospitals and the physicians for not being satisfactory, giving satisfactory care. So thank goodness we've gotten rid of pain as the fifth vital sign, because it was had kind of a cascading effect in terms of pain management. So then we were looking at healthcare incentives. We talked about that in terms of, the pharmacy salespeople would come in and say, well, if you use this new drug that we have, we're going to sponsor a nice lunch, a seminar for your staff, or we're going to, send you on a trip to a conference or something like that. And I am sure that that probably still occurs, although again, governments have kind of come down and tried to, curb some of these incentives. But it is a sales thing. These drugs make lots and lots of money for the manufacturers. So they want to get as many of them out as possible. And also the other thing, which is really not on here, but and that's probably more of a cultural or societal thing, we do not value as much as other countries do alternative measures to alleviate pain. We have some integrative health and that kind of thing where people may do physical therapy, they may do mindfulness practice or meditation practice or yoga or something like that. But we don't really value that as much. It is getting better. I know some insurance companies may cover some of those practices, but in general, we don't really look at them as being as helpful as being able to take a pill. Okay. And then, of course, dosage and duration. If you're on a medication for a longer duration, or you're on a higher dose of medication or an opioid, of course, you have a higher risk of becoming addicted. That's just kind of the way it is. Certain drugs are more risky for addiction. For instance, if you remember back to the cocaine epidemic in the 80s and 90s, People were becoming addicted to cocaine after the first or second use. And then when it became, people were manufacturing it as crack cocaine, very highly addictive because it gets immediately to the brain. Anything that you smoke, any drug that is smoked goes almost immediately to the brain. Obviously the same with injection as well. So, the longer you're using an opioid drug, even if it's a legitimate use, it can, increase risk. Okay. Any questions? Because this has been a lot of information so far. All right, so who is affected? Youth or young adults age 15 to 24, these are the overdose deaths. You can see it has gone really, really, really high. It dipped a little bit and then has gone up to right now 7,426. So youth and young adults are disproportionately affected. If anyone, the mean youth age of first use is 15. And so they perceive it as being low risk. Young people see if it's a pill, it's safer than if I inject it. If I get it from my family or, my parents' medicine chest and it's prescribed, it must be safe. And that we know that's not the truth. So this has increased 49%. And then, again, this is the same up to 2021, I believe. So still is going up high. 84% is opioid related, and 100% is fentanyl related with teens compared to the whole United States. Okay. We see overdose rates by race and ethnicity. Again, a rate is a number per 100,000 people. So we can see here, American Indian, Native Americans, I should say there, Alaska Native, 85% rate of opioid misuse. Black, 78.2%, white, 40.4%, Hispanic, 66.1%. So we know, by race and ethnicity, there are varying degrees of or numbers of rates of the use. Increased risk of opioid misuse among LGBTQ populations. In 2018, the study estimated 5% of adults misused opioids in the past year, and that is who identify as heterosexual. It was 9% for individuals who identify as gay or lesbian, and 12% for those who identify as bisexual. So again, this is 2018 data. It's the latest that we have in these slides, but I would bet anything I own that these rates have gone up recently. So, primary care providers, educators, and even parents should consider sexual orientation when assessing those at risk. Not only do we need to consider it as a risk factor, but we need to monitor the groups more closely once they've been identified. So, recognizing and preventing an opioid overdose. So, who is at risk for overdose? Well, we just saw, in terms of our, different populations in our country, different cultures, youth, certainly, but who else? Who in general is at risk for overdose? People that get opioids from multiple sources, people who use for non-medical reasons, or use opioids prescribed to others, take more than or more often than they're prescribed. Former opioid users who may recently have been released from prison or treatment. And I want to take a minute on this. People who have been incarcerated or in residential treatment will drop their tolerance to the drug. And what we mean is when somebody uses a drug over time, they develop a tolerance, meaning that they need to take more of that drug to get the same effect. So this can even happen if you're taking, you know, a regular medication for a chronic condition. You know, eventually that medication dose may have to be adjusted because you've developed a tolerance to it. It's not working as well. But when somebody's been incarcerated and have had a period of abstinence, if they get released and immediately use again, they have no tolerance to that drug. So we see a lot of overdoses occur from people leaving prison, or again, from treatment. Or sometimes people who know they're going to be incarcerated, you know, the day before, they may use more just as a send-off. You know, I'm not going to be able to use for a while, so I'm going to, you know, use as much as I can now. So that's a special population of people that we need to keep an eye on as well. People who snort or inject the opioid, remember, if it gets in a mucous membrane, it will quickly get into the bloodstream. Elderly people prescribe opioids. And so sometimes, and again, children who accidentally take opioids, we think, I do a lot of Narcan training as well. And we, you know, when we're talking about assessing, is this an opioid overdose? You know, do we need to give Narcan here? Sometimes people are not abusers or misusers of an opioid, but they may be prescribed and just maybe lost track of if they took the medication or not. You know, I'm on pain medication and I don't feel well, so I'm going to take an extra one. It'll help me sleep, etc. Or children who accidentally take opioids. And we do hear stories about this, you know, somewhat often about, you know, illicit, you know, methadone may be taken accidentally, and not that methadone's illicit. That's a little bit different, but, you know, we hear people who are not, you know, keeping their drugs out of harm's way when children are involved. Anyone who's on high doses of opioids, even if taking medications as prescribed, you know, again, a high dose of opioid, you just don't know how it may hit you at a certain point. People who are using pain relieving patches incorrectly. I don't know if you all have heard of these patches, but they are similar to like a nicotine patch, where they are, it's fentanyl patch. It's used, one patch is used for 72 hours, and it is like a time controlled method of releasing the drug into the person's system. So it goes through the skin and is not absorbed as quickly. So it's kind of a slower, gives you kind of a more steady dose of the medication in your system. It's not hitting it right away, but it's kind of, you know, taking the edge off of that pain over time. And people use the patches and, you know, just put them on every 3 days. But we see a lot of people who are misusing pain patches, fentanyl patches. They put more than one on their arm or their chest where they put the patch, usually the arm. They may cut the patches open and squeeze out the fentanyl gel that's in the patch and either ingest that or smoke it. They may chew on the patches to get the fentanyl. And keep in mind, that's 3 days worth of fentanyl medication. So we see a lot of near overdoses occurring from these. People taking multiple respiratory depressants because opioids do slow the respiration. They slow the breathing down. They're depressant drugs that are kind of slowing everything down. So people that are taking other medications that may cause, you know, maybe depressants, may have, you know, even some allergy medications that could be, that could affect, you know, put them more at risk for overdose. And people with chronic lung disease or sleep disorder. All right. So signs of prescription opioid misuse, and I have this in a, I could send this to you all if you would be interested in having this or any of these slides. I can't give you all of them, but I can give you this one because a lot of people request this one, and it's a pretty lengthy slide. Let me look at this chat first and say, yes. Hortense is asking, did you say when you come out of prison, your level of tolerance is lower? And that is correct, yes. You do not have the tolerance that you would have built up had you been a regular user prior to prison. So we do have to take, you know, measure of our folks that are incarcerated, because we do know that most people that are incarcerated for shorter sentences. Not everyone goes for life or for 20 years. Some people are in maybe 2, 3, 5 years. Their tolerance is lower, and we need to, do some good pre-release work with them. And we do that in our county here. We give them Narcan. We talk about release. We talk about tolerance, all of that. So yes, Joy, I will send you this, or once I get everyone's emails, I'd be happy to even send this to everyone, because this is a pretty good slide here. You can see we're looking at, let me go back here, physical signs, health signs, behavioral, environment, and what you may notice are fine. We give this out like crazy at health fairs to parents, but and I'm not going to read every one, but you can see physical. There are some signs there that are very typical of opioid use. Covering arms with long sleeves, maybe wearing a jacket when it's 90 degrees out, lack of hygiene, and overall kind of an unhealthy look or slurred speech. We might see weight loss in terms of health. You may see a lot of nausea, vomiting, depression, changes in appetite or sleep. Behaviorally, we may see someone kind of nodding off. And a lot of times, this is a couple of times, I carry Narcan with me when I go out. And, a lot of times you may see people who are in their car and they're kind of nodded off. And then you wonder, is this person maybe having an overdose or not? So I'm always kind of aware of that. They may lose friends they've had a long time. Obviously, this is in any addiction, problems in school or work, trouble with police, loss of interest in things that may have interested them before, etc. We might see in our environment at home, is money missing, or are prescriptions missing? Are they asking for money a lot? Is there secretiveness going on? Are we getting, secret phone calls where the person takes the phone to another room to talk, or kind of looks, like they don't want anyone to hear this phone call. And then you may notice things that are used in the use of drugs. So bottles of bleach or vinegar, cotton balls, Ziploc baggies, or paper folded into small envelopes or small packets. Those are all things that may be used with someone buying heroin or powdered fentanyl. It's hidden in a baggie. If someone is injecting, they're going to use bleach to clean the needles and their syringes. They're going to use a cotton ball, which they put into a spoon or maybe a bottle cap, as you see on the list on the right. And then they inject through the cotton. They cook down with some water, and then whatever the powder is, they burn it on the bottom with a lighter, like a little pan, and they burn it with a lighter, and then they may pull up the syringe by put the needle into the cotton ball, which serves as a filter, and then pull the medication up into the syringe and then inject. So those are all kind of things that you may see that could raise a red flag. We do a course for parents on going into a child's bedroom and looking around, and if you see some of these things, what could be a sign of substance use. And certainly having loose change with powder on it, or straws cut in half, or spoons with burn marks. We've had parents say, I don't know why, but I'm missing all my spoons. Well, that's a red flag right there. So I will send you all this. Write a note right now. Send signs slide. And this says heroin on top, but this is for any opioid that could be injected, or really any opioid. Okay, so opioid overdose signs and symptoms. When we teach our Narcan class, I don't teach it for the university. I do it on the side, but some of the things that we want to look for is a person unresponsive to a sternal rub. If we see someone who is unconscious or seems to be nodding off, the first thing we want to do is kind of try to wake them up. A gentle, maybe a nudge or a touch on the shoulder, a talking, hey, I'm here, are you okay? you know, did something happen? Are you having a medical emergency, etc. But if we can't rouse them immediately, we can use a sternal rub. And if you are a medical person, you know you would take the knuckles of your hand on your fingers and rub it on their sternum, which is their breastbone, right in between the ribs and on their chest. And that is a very painful thing to have done to you. So most people, or many people, that may wake them up. If they can't be awakened or can't talk, they may have pinpoint pupils, bluish lips or fingertips, vomiting, gurgling, or choking noises, and then small breath, respiration, or heartbeat. All of these are what we look for when we're looking to see if something's an opioid. Yes, Hortense, I will send you that as well, that information. Thank you in the chat. All of these are signs of a possible overdose. So what we want to do is to immediately call 911. I always tell the folks that I train that if you have your cell phone and you call 911, explain what's going on. You know, this person is in the Walmart parking lot and they're slumped over their car and I can't seem to wake them up. And I see, you know, a syringe next to them on the seat. You know, you want to report everything you can to the 911 operator. It's always good to look around and see what's there. Is there anything you can get hurt on? Is there anything obviously that looks like it could be a use of a substance? And then put your cell phone on speaker and put it down and try to administer aid to the person. If you have Narcan, you could administer Narcan. Many of you may have it. If you don't, you can get trained in how to use it. It's very simple to use these days. And it can be, you can get it at your local health department, or if you go to the state of Maryland Health Department website, it'll tell you how you can get Narcan for free. But what is Narcan? It is an antidote or an antagonist. That means it reverses and blocks the effects of the opioid and restores breathing to the person. As we said here, during an overdose, respiratory and central nervous systems are depressed and breathing ceases to be almost non-existent. You might have a person that only breathes maybe once or twice a minute. So it reverses an overdose. Narcan has one purpose, or naloxone, either one. Narcan is the brand name that is used. It blocks the effects of an opioid and reverses an overdose, allowing the person to breathe normally. So it has one purpose only. Narcan will not, you know, end their addiction. It will not take the drugs out of their system, but it will restore their breathing. It will not get a person high. It's not addictive. And the important thing is it will not harm a person if opioids are present or absent. It cannot harm a person in any way. It's very safe to use. It can be used on children. We've had people use it on their pets if their pets have accidentally ingested an opioid. And in fact, we've worked with some veterinarians in our community and they carry Narcan in their practice and recommend it to their patients, for their patients' mom and dads. So used to be that it had to be injected. If a person is, you know, if they've overdosed and you've called 911 and the medics come, they may give naloxone intravenously in a medic unit or in the hospital, or intramuscular, where you see you have to draw it up from a vial into a syringe. What we give out is intranasal, which is like a nasal spray. This is the one we give out in our county, the one with the pink lettering. It's like a little plunger, and this little part at the top there goes into the person's nostril. We give a supply of 2 of them. And all you do is put that in their nostril. You push that little pink plunger on the bottom, and it's just like using a nasal spray. And then if we ask to wait 1 to 3 minutes and then give the second dose of Narcan. We are actually, parts of our county now are looking into providing 3 of the doses of Narcan, because again, fentanyl, it's, you know, we're talking about that tolerance, but fentanyl, you know, people get a higher level of an opioid in their system when they're using fentanyl. Okay. And then obviously we'd like people to kind of wait with the person until the medics get there. Our hope as people who are in the field that I'm in is to, you know, have the person who has overdosed at least go with the medics to the hospital, because that can be an entry possibly into some treatment down the road. Our hospital here, we do have a substance use treatment facility. And we also have peer support people at the hospital. So when someone comes in due to an overdose, we link them as best as we can in that setting. Again, things to know about naloxone: it's very easy to use, easy to store. Just don't store it in your car or exposed to extreme elements. You don't want it to get too hot or too cold. It will not hurt someone who is not overdosing. So say you've gone to that car and somebody is slumped over and you're not sure what's going on, and you call 911 and the person is just, you know, not breathing or breathing very slowly. You can give them Narcan. It will not hurt them. So even if they're having, even if they just fainted from something or having another medical situation, it will not hurt them. It won't help them, obviously, unless there's an opioid present, but it will not hurt them either. So it does save lives. It's a harm reduction measure. Again, it's not going to solve all the addiction issues with that person, but it will, you know, reduce the harm of their use. So state laws allow the prescribing to individuals who are prescribed opioids, to the public, or just to lay administrators. You know, the normal person on the street like you and I can get Narcan. You can get it from your pharmacy, although you would probably have to pay for it there, or through a health department. Okay, so we also have, in Maryland, we have a couple of different Good Samaritan laws, but in general, a Good Samaritan law means that bystanders can administer help, including naloxone, without fear of arrest or other legal complication. The general Good Samaritan laws talk about removing liability for healthcare professionals' provision of naloxone, or for a first responder or lay person to administer naloxone. So that's kind of like the old do no harm kind of statute. You know, were you acting in good faith? If you see a car accident on the side of the road and you stop to help someone, you are not liable, you know, for what may happen due to your helping that person if you were acting in good faith. And this is kind of the same thing there with the naloxone use. Okay, how to access it: your state or local health department, local pharmacies. Sometimes if you have a family member who is either prescribed opioids or may, you know, have opioid misuse issues, or, you know, using opioids illicitly, insurance may cover that. And sometimes local nonprofits have grants to provide it as well. Okay, so Casey is asking the question, why several doses of Narcan may be necessary in an overdose situation. Remember when we talked about it only takes a tiny little bit of fentanyl cut into something for it to have an effect or to be lethal. Fentanyl is extremely powerful, 50 to 100 times more powerful than morphine, which is what they give us in the hospital when we have surgery. So when we're all knocked out. It is necessary because when someone who is illicitly manufacturing drugs or dealing drugs, they don't measure out like in a recipe, like, well, I can only add this little bit of fentanyl to this. You know, everything is mixed together. It's all cut together. It's mixed up in a powder, and then it's bagged up in a little baggie or a little envelope, or, you know, a little container of some kind. So the person does not know how much of that fentanyl or of any opioid, even with heroin, that they are getting in that dose that they buy. You know, person A may buy from one dealer, and person B may buy from the same dealer, but they've gotten 2 different levels of fentanyl or of heroin in it. So we don't know how much is actually in it. There's not a way to measure. I guess purity is the word that I should be using. You know, we don't know how pure something is. So, for instance, usually 1 to 2 doses is helpful. That's why, you know, we have given 2 doses historically. But we did a training one time, and a woman told us that she and her husband had to give 7 doses to someone. It was a person they knew. It was someone they were familiar with. The woman was in the addictions field, and this person had gotten his hands on what we call carfentanil, which is even more deadly and more potent than street fentanyl. And this was, you know, around the area where I live. And this person, and we have not, by the way, seen carfentanil since then. It's very rare. I think it was that phase has kind of died out because it was so lethal. But she gave 2 of her doses. Her husband had 2 Narcan doses. And then they were going through the house looking if they had any expired Narcan or if there was anything else. And they had to give 7 doses to bring this guy back. So again, he obviously got a batch of illicit fentanyl that was extremely concentrated batch. Luckily, he was in recovery. The last I heard, it's been a couple of years, but you know, we just don't know. There is no predictability to how a person will react to it. Okay. Okay, and then Good Samaritan, I'll send that to you guys. Good Samaritan info. Thank you for asking the question, though. You know, it just has to do with purity. And like we said, sometimes when people get word that the heroin or the fentanyl on the street is, you know, more concentrated or more potent, they want to use that because again, that's, you know, that's what propels the addiction. Okay. So thank you all for these really great questions today. Okay, so general information, we talked about this a little bit. I know our time is clicking. So making it available does not encourage people to use more. It's a bridge between the call to 911 and when help arrives. It has no effect if you're not suffering an overdose. Repeat in 2 to 3 minutes. And here's another thing too, lasts for 30 to 60 minutes. So the half-life of the opioid may be longer, so there is a risk of re-overdosing. So that's why it is so important to call 911 and try to keep the person there. If they're coming out of that overdose, the person may want to leave. They may be afraid, they may be embarrassed, they may be angry, but we want to try to get them to, you know, rest and stay safe until the medics get there. Okay. Best practices, I'm not going to go too much into this because of time, but some of the things that we can do or we can promote in our communities or advocate for, you know, educational programs beginning in schools as young as grade school, in age-specific, age-appropriate ways. Parents and community members can be educated through community forums, etc. Safe prescribing, like we said, you know, we can ask our doctors about non-opioid solutions to our pain, or for, you know, to use less medication for the least possible amount of time. If you're a patient, you know, be informed, ask physicians. We used to do a program here where we would help people feel comfortable asking their physicians questions about, you know, are there alternatives? What are the guidelines? What are the risk factors? You know, when can I stop taking it? What if I feel sick when I take it, et cetera? You know, our doctors we pay them, you know, they work for us. So we can, you know, we can try to feel comfortable asking those questions. And I think physicians now are more attuned to these issues. Again, in terms of prescription medication management, secure it, dispose of it. There are local prescription drug sites that you can dispose medications. Usually at law enforcement offices, there will be a drug drop box. And sometimes they will also twice a year, April and October, the DEA sponsors Drug Take Back Day. And I know in our area, all of our law enforcement agencies have drop boxes and they have big events for Drug Take Back Day. No questions asked, you just bring it up and drop it off. We talked about the data and prescription drug monitoring. So, we're always looking to improve that program through collecting that data and communicating with nearby states. Early intervention, obviously, the earlier we intervene in a situation, whether it's a mental health situation or a substance use situation, the earlier treatment that we get is going to help with recovery or even prevent. And then language, substance use is one of the most stigmatized illnesses out there, and we know that. But the language that we use can help maybe do some good toward destigmatizing it and getting people into treatment. Because if a person feels stigmatized or judged or stereotyped, the last thing they're going to do is put themselves out there and say, I need help. And that goes with families as well. And I could certainly send this one too, because I'd love this slide. You do stigma. I'm going to send you guys this one too. Might not be today, but it'll be soon. I'll get this sent to you. So we want to use words that don't sensationalize it. This is a substance use disorder. We use people first language. We don't say that person, that drug user over there. We say this person who has a substance use disorder. We are all made up of many facets, and someone who is, kind of struggling with or learning to manage a chronic illness is only a small piece of who they are. So we want to avoid negative terms. We want to, in terms of describing the person or the problem, because we don't want to, again, sound judgmental toward this. And this is tough. I will totally admit that it's really hard if we've grown up with certain language. And then, the world is trying to get a little kinder, and we're trying to get a little more understanding and compassionate toward people. So we want to work toward that. Okay, harm reduction. I didn't realize this is going this long, but I'm going to go zip through these. We do, of course, also on harm reduction. So if you guys would like, in fact, I think we may be doing that for you all. So go through this kind of briefly, but all harm reduction is reducing harmful consequences with human behaviors or practices. So sunscreen is a harm reduction, right? We're not going to avoid the sun the rest of our life, but we're going to kind of lessen the risks, right? Bug spray is another one. Bike helmets, vaccines, nicotine gum or patch, that's not going to cure you of your addiction to nicotine, but it's going to help you work on the other things you need to quit smoking. Condoms are a harm reduction measure. So then when we look at, seatbelts, car seats, airbags, designated drivers, all harm reduction measures. Again, not making the problem go away, but making it safer for the person using or, driving, for instance, or riding a bike. So when we talk about opioid harm reduction, naloxone, certainly. Right now, a lot of the health departments have fentanyl test strips. So if a person is going to use, they can get a little kit that will tell them if fentanyl is in their drug. And by the way, fentanyl has been found in marijuana. So now that marijuana is legal, we need to keep in mind that it could have fentanyl in it as well. So fentanyl test strips can save lives. Medication-assisted treatment like methadone, etc. Okay. Treatment and recovery, we know that we need varied continuums of care for treatment. Options can vary, can be inpatient, outpatient, might be peer support, detox, etc. We want to basically, this is all, this is what we talked about, is just the safety, the harm reductions, reducing stigma, etc. Prescription management. And prescription management is something all of us can do. It doesn't even have to be for opioid drugs only. Any substances in your home that could be harmful, we just need to store them carefully, keep track of when we take them, or if we have a child on medication, keep track of when we gave it to them and what the dose was and how they're feeling, etc. Okay. I know I'm going through because I'm conscious of your time. So end notes, so steps that parents can take. if, we have to look at the risk factors, youth look at risk of drugs as being low. Youth look at the risk of doing anything as being low risk, because we know, they're risk takers, they're growing, they're changing, they don't have a good sense of how dangerous things can be. So these are the things that we need to keep an eye on. If their friends are using, are they really young when they may start using or talking about using or using drug-friendly language? We have to model what we want for our kids in terms of all healthy behaviors, right? So steps that we can take, we can educate about, what the risks are. We can discuss it. We can talk about non-substance ways to cope with problems, to have fun, to deal with stress, encourage open dialogue, knowing prescribing guidelines, and screening and early intervention. Now, if you all do not get the ROPTA newsletter, I would encourage you to get on our list, and I can also send you that information, because we do a newsletter every month, and I do a little prevention corner just with tips for parents or for interested, concerned adults. And all of this we've kind of covered. Just going into a little more depth, which I don't want to take your time for. So basically, if many people in many places, what happened to my slide there? Do many little things, we can change the effects of the health crisis. So if we just begin by opening dialogue with our kids, even when they're 5 years old, we can talk to them about being upset and how to handle that, or, feeling, if they don't want to do something, what should they do? Or, don't let someone force them to do something they don't want to do. We can start really, young age, and we don't even have to mention the word drug. We can just talk about being safe, making healthy decisions, etc. Choose empathy, not judgment. Remember our language, and the prescriptions, and call 911 always. So there we go. Overdose Lifeline. Again, we thank them for allowing us to use their curriculum and their slides, and I encourage you to look them up. I will be, yes, Maryland Coalition of Families. Thank you, Casey. Yes, absolutely. Wonderful, wonderful group of folks that we work with very carefully with ROPTA. If you, I will be sending you an evaluation link. If you would be kind enough to give us a good not a good evaluation, give us an evaluation about this program and how, what your feelings are about it, how we can improve it. But we always want to be relevant and timely, and, make things understandable. And, when we get new information, we like to pass that on. So you will be getting a link. If you just click on it, it'll take you right to the evaluation, and it probably take you 3 or 4 minutes. But I thank you so much. I'm sorry we went a couple minutes over, but I so appreciate you giving time today.
Thank you.
And thank you all. And I will send you the information to, do we have a slide in here about ROPTA? We should, but we don't. So I will give you guys the information on how to subscribe to the ROPTA newsletter. But if you just Google ROPTA, R-O-P-T-A, University of Maryland, you'll see we have a social media presence, we have a newsletter, we have a website. So please access that. And we will, like I said, we have a couple more of these Overdose Lifeline programs coming your way, I believe, in the next couple of weeks. So really glad to be with you, and hope this was helpful. And we will see you again soon, probably next week. All right. Thank you all so much.
You too.
Have a great day.
You too.